So we're going to go ahead and get started. As people file in, I'm sure that they can catch up on this. I bounced some ideas off Krista as far as what in oncology we should talk about. I'm located at the University of Colorado. It's an academic institution, and so I'm very fortunate to work just down the hallway from all of the oncology. We don't have a derm-onc specific service, but we do offer it as curbside and consultation. So it's a privilege for me to be here to offer some of my insight to kind of empower you guys to do some dermatology with your oncology patients. So I wanted to choose a topic that kind of hits home for everybody, and it really starts with the nurses. So I hope you guys enjoy some Paritis. I promise there's no pictures of bugs. No disclosures that I have to offer. So when we talk about Paritis, the most important thing is that we start with the actual definition of what is Paritis. So itch is a topic we all can relate to, whether or not we're sick, we're healthy, we're young, we're old. At some point in our lives, we've all been itchy. The formal definition of Paritis, or itch, is an uncomfortable sensation that provokes the desire to scratch. Chronic Paritis is considered lasting greater than 6 weeks. Can any of you imagine being itchy night and day for 6 weeks? It's miserable. And it's not something a lot of people talk about. We talk about pain. How's your pain level? Tell me about your pain. And while that's important, so is itch. And in dermatology, that's a question I ask patients. I say, is anything itchy, burning, bleeding, painful? And patients want to hear that. They want to hear the acknowledgement that it's okay to say, yeah, I'm itchy, like something's going on. So it can be hard to manage as providers, but more so for patients, it can be debilitating, not just for them, but for their family and also for their caretakers. The pathogenic function of itch is not well understood. What we know is it starts with the skin's free nerve endings, which are most concentrated on our wrist and our ankles. The itch sensation is transmitted through the C fibers originating superficially in the skin. The impulse is then conveyed to the dorsal horn of the spinal cord and then to the cerebral cortex. A spinal response is generated, and that spinal response is a itch, which initiates a deep tendon reflex. The pathophysiological consequences of this itch can be as much as pain and the impact on life for our patients. The pleasure that we get that accompanies the scratch reinforces this motor activity and further ensures the neuroimmune communication. So what happens? The more you scratch, the worse it gets. There's no signal mechanism to explain all causes of Paritis. However, for our patients that are on targeted anti-cancer therapies, we can talk about alterations in the skin barrier function and homeostasis, Paritis preceded by dry skin and inflammation, and an increase in the dermal mast cells induced by the targeted therapy. Histamine, which we hear about often, it's a chemical, it's a mediator for itch in conditions like bites and stings, but it has little to no role at all in systemic forms of itch. There are 5 different classes of itch: dermatologic, systemic, neuropathic and psychogenic, and mixed, meaning you have more than one of the above. Do you think that most patients have mixed? Yeah. You know, we're human. It happens. Patients don't come in with a clean slate of just one problem. So let's dive a little bit deeper into those causes. Let's think about infections. Lice. It happens. It happens to us all. Nothing to be ashamed of. Scabies. Scabies happens. Quite common. HIV. Patients can get itchy with that. Environmental. We often think about allergic contact dermatitis if you're out in the woods playing with the poison ivy, or a photodermatitis reaction. Skin disorders, dermatological conditions that can lead to itching, psoriasis, seborrheic dermatitis, or just good old-fashioned dry skin. Medical issues, diabetes, thyroid, cholecystitis, anemia. Medications, one of the most common ones we think about are opioids, but also our EGFRs can cause itching. Pregnancy is a common time that we get itching, and also aging. Over the age of 70, you're at an increased risk for Paritis. In our cancer patients, some of the most common causes of Paritis include senile, which is not my favorite word, but you will see that quite common in the literature. Senile, think about pretty much over the age of 65, 70. Cholecystitis, we talked about some of the skin dermatoses, some lymphoprolific disorders, the drugs, uremia, paraneoplastic, and psychogenic. For our cancer patients, the impact of Paritis, it's not well known, it's not well studied. But the incidence is likely increasing because patients are receiving more of these targeted therapies. It's reported about 20 to 30% of patients undergoing cancer treatment suffer from Paritis. That's huge. 20 to 30% of people are itchy. Why are we not talking about this? So we know that we use a lot of EGFRs as targeted cancer therapies. They fuel the growth of cells in our hair, our nails, our skin. They're important. But what that also means that we can get some changes when we're using these drugs to treat the cancer in those areas, hair, skin, and nails. The incidence of a high-grade Paritis in patients receiving EGFR is substantial. The literature review I did said between 15 to 60%, and if patients are receiving long-term treatment, it goes up dramatically higher. The Paritis affects the quality of life as well as our clinical outcomes of anti-cancer treatments. It alters the dose medication, and sometimes we have to discontinue treatment due to the itching. Additionally, patients carry a social stigma, when they're itchy. It harms their relationships, it decreases their incomes because they can't go to work because they're itchy. It also impacts their mental health. And we worry, about accidents and infection. If these patients aren't sleeping and trying to navigate or drive a car, guess what can happen? They can get in a car accident. Or if they're scratching their skin so aggressively, they can introduce an infection. So now we have another problem. So potential side effects of Paritis. So physical is something we all can see. You can see when somebody's itching. They're sitting in front of you. They're going to town on their arm. They have these nice straight lines. But there's more that's, under the surface. They're not sleeping. They're not going to tell you they're not sleeping. Usually it's the spouse. I'll say, so how's it going at home? Well, he sleeps in the other room because he scratches all night. Well, now we have a sleep disturbance. If you're not getting the sleep you need, your body's not recovering, and it's not going to do well through the treatment for the cancer. Decreased appetite, that's another concern. Psychological, these patients have anxiety, they have depression, they're irritable, they don't feel good about their body. Socially, they're isolating. Who wants to go out and have dinner with their family when they're just sitting there itching all the time and can't focus on eating? They're embarrassed of the way their skin looks, and they have strained relationships. I had a patient in her 70s last week who came in, was new to me. She had been itchy on and off for 5 years, kind of comes and goes. She has some treatments that kind of work, but not really. But her goal this summer was to get to a family member's wedding. And she said, I don't think I'm going to make it because do you see my ankles? Do you see how bad I look? So she has some social issues about it. She's embarrassed. She can't make it to a family wedding. I feel awful. So my goal is to bring her in, do what I can with that goal of getting her to the wedding to improve relationships and also how she feels about herself. So we're going to take a trip back to nursing school. We're going to go with the nursing process. So I know you all remember this. It was drilled into us for many, many years. So as nurses, we play a pivotal role about treating patients. We provide holistic assessments, we deliver, we monitor treatment, and we provide support to patients and families. So the nursing process is our most important tool for putting our knowledge of nursing into practice. We know it's a systemic problem-solving method to determine the healthcare needs of an individual and provide personalized care. We know it's collaborative, we know it's dynamic, and it requires a lot of critical thinking. So the first step in our nursing process is our nursing care plan. We know that a nursing care plan is how we follow a patient's condition and how we best care for them. We document their needs, their wants, and interventions, and how we're going to help them meet those goals. This becomes a part of the patient's healthcare record, and the care plan is used to establish a continuity of care and clear communication by all medical professionals that are involved in care of this patient. We know that it enhances communication, provides documentation, helps with reimbursement, and continuity care across the healthcare system. So the first step in the nursing care plan is our assessment. So I'm going to kind of walk you through what I do of an assessment for paritic patients when they come into my clinic. So the number one thing I want you to remember in the takeaway is I want you to listen. I don't want you to rush in and start asking questions. I want you to have them open-ended. I want you to allow that patient to feel comfortable to share with you. Itching is a very personal thing, and they need a safe space to talk about it. So many years ago, I took a class on communication, and the takeaway from that was, tell me more. What else? What else? What else? And I thought, oh my gosh, I'm going to be in the room for 15 minutes talking to this patient about their right foot and how they're itchy. I don't have time for this. But it works. Letting that patient spill everything out, they will give you the majority of what you need for the questions. And if they don't, you circle back around at the end, and they feel heard. And that feels good as a patient to be heard. So the data that we're collecting from the patient at this point, we know is objective. We also have subjective. It can be verbal, but it's also nonverbal. I want you to sit, observe the patient, see what they're doing. How are they holding themselves, their posture? Who is the source of the data? Is the patient not talking? Is it the caretaker, the wife, the spouse? So I first start with the interview of the patient. I second examine the patient while observing them the whole time. So let's talk about the assessment. So patient comes in and I say, tell me more about your itching. And then they start talking, and they start talking. And it's good. As they go through, I just make notes. So if they don't hit anything that's on my tick list, as you see up here, I circle back around and try to leave that open-ended. So you want to know, when does this happen? When are they itchy? Is it first thing in the morning? Is it all day? Does it wake them up in the middle of the night? How does it feel? And for some patients, they can describe it some right away. Other patients need some clues from you to describe. Is it burning? Is it tingling? Does it feel like there's bugs climbing all over your skin? And where's it located? And they always go, it's all over. No, where is it? It's all over. Okay, how about you point? And then they'll start and say, well, actually, it's not my head, it's not my mouth, it's not my ears. It's mostly my wrist and behind my legs. Great, we've kind of deducted a little bit further down. Ask them what makes it better. Ask them what makes it worse. They'll say, no, it's nothing at all. So I'll say, what about the weather? How about activity? Does it happen when you're eating? Oh yeah, it does. Now that you say it, this is what happens. Also, if you don't ask some of the questions, they don't think to offer it up. In America, people think we should shower once or twice a day. We shower way too much. If you don't ask how often they shower. Oh, like a normal person. Well, what's normal? What is normal to you? I write that down, and they go, is that good or bad? It's whatever you do. We're just going to write it down. I ask them what products they use. This is where it gets tricky. Oh, you know I use that soap, the white one. Nope, I don't know what soap that is. Oh, it's the green one. And I go, the green one that smells really good? And they go, yeah, do you know it? And I go, as I'm cringing. Often if a patient can't recall what they're using at home, I make them bring a bag of everything in, or I make them take photos. Many years ago, I had this sweet little 90-year-old come in with his wife, and he goes, I'm itchy. And I said, okay, well, what are you using at home? I don't know, I use soap, whatever my wife gives me. She has no clue. So I said, how about next time you come in, bring your brown bag, and let's go through it. He pulls out his soap, and he's using Palmolive dish soap. I cringed. And I said, oh, dear, dear, dear. But you don't know that until they bring it in. So have them bring in a goodie bag, and you'll see they're using their husbands and their kids and the dog salve. I mean, people use everything under the sun. And it's fine if they pull out 50 things. I write all 50 things down in my chart that they're using. That's good. People get really offended when you're like, oh, that's horrible, you can't use it. So I try to use nicer language, and we can talk about that a little bit further down. What makes us feel better? Lots of people say, oh, I get in the hot tub, I get in a cold shower. Some people, not at all. Do they have any history of asthma? Do they have history of allergies? Have they been traveling? We're all starting to get back on planes now. Or did they get in the car and go up to Breckenridge and go on a long hike? Do they have any pets at home? Who else lives at home? Who do they share a bed with? What is their sexual history? What do they do for work? It's a lot of information, and sometimes patients feel a little bit bombarded, but you have to keep kind of digging and just document, and at some point you do get to a cause, sometimes you don't. But you don't know until you've asked those questions or allowed the patient to explain it. So for the physical exam, I have patients stripped head to toe in a gown. I just don't want to see your foot that's itchy. I want to look at the rest of your body. How is their skin? Is it dry? Is it flaky? Is it warm? Just go back to what we were taught as nurses on a general, nice skin check for patients. Check the temperature, check, cap refill. Is it red? Is it swollen? Do you see any lesions? I'm not going to ask you to describe what a weird lesion is to you. Do the best you can. Don't be afraid to take a picture and put it in the chart and say, please refer to picture of left arm. How's the patient doing? Are they calm and chill? Or are they actively scratching and they can't talk to you and they're up and they're moving? Finally, I go through the chart. Sometimes I do this when the patient is present. Sometimes I wait till afterwards. I want to know if there's anything systemic going on with that lab work. Have they had an x-ray? Do they need a biopsy? Are there any photos in there? Do I need to take photos? Often patients will come in and they'll have a ton of photos on their phone. And I have them send them to me via my Health Connection, and it becomes part of the medical record. Because that's a timeline that we can use to follow their progress. And it's also nice down the line to show them the photo of, this is what you look like, and this is where you're at now. So next step in our nursing care plan is a nursing diagnosis. How many people remember nursing diagnoses? With Paritis, this was very applicable. As we know, a nursing diagnosis is a clinical judgment concerning a human response to health conditions, life processes, or vulnerability for that response by the individual, family, group, or community. A nursing diagnosis provides the basis of our selection for nursing interventions to achieve outcomes for which the nurse is accountable for. They don't reflect, the nursing diagnosis not only reflects the patient is suffering from Paritis, but also the other problems that we've already kind of talked about that the Paritis is causing. Is it anxiety? Is it infection? Is it poor nutrition? Are they having conflict with family members? Did they lose their job? Or the potential complications it has to cause. For example, that skin infection. This is the basis for our nursing care plan, or our nursing diagnoses. What's the difference between a medical diagnosis and a nursing diagnosis? I'm a nurse practitioner, I write medical diagnoses, but sometimes I bring my nursing diagnoses into my care plan and document with it. I combine the two. Is there anything wrong with that? No. I think it better serves the patient because we're going back to that holistic assessment of the patient. The nursing diagnosis is specifically handled through nursing interventions, while the medical diagnosis is made by a APP or a MD. And the nursing diagnosis, it can be mental, it can be spiritual, psychosocial, it can be physical, and it focuses on that holistic overall care of the patient, where the medical diagnosis just involves the medical aspect of the patient's condition. The medical diagnosis doesn't change even after it resolves. It's still part of that patient's medical record, where our nursing diagnoses are fluid and they can change over time, and they also are generally for just a specific period of time. So for our paritic patient, an example of a nursing diagnosis would be impaired skin integrity or risk for infection due to fissures of the skin. So we need to have some outcomes for these patients. What are our measurable goals for the patients that are paritic? They can be short-term, they can be long-term. They need to be documented, because if they're not documented, we can't work as a team to take care of this patient. So for a dry skin patient, we could say, patient will verbalize dry skin care to improve Paritis, or patient will be free of itch at night. These are all measurable goals that then we can circle back around and document in the medical record for the patient. So our fourth step in the nursing care plan is implementation. How do we manage it? What are we going to do for the patient? We're going to use nursing interventions. Remember this pyramid many years ago? So think about Paritis. Think about what we've talked about, how Paritis impacts the patient. So we're going to try to shoot for levels maybe 1 and 2. We want to make sure patient has air. Probably with Paritis, this is not an issue. Food, did we talk about how you're itchy and you don't want to eat? Absolutely. So this is something we need to make sure we're ticking off the list for the patient. How do we make the Paritis manageable so that you're getting healthy meals and good water intake? The next step up would be safety. So think about employment. What can we do to get you to work every day? How can we make this happen? Third goes back to my patient about the wedding. You know, she wants to feel loved. She wants to be a part of her family at that wedding. So what steps can we take? But always remember, we're starting with the basics of air, water, food, sex, and then work our way up on that pyramid for Maslow's hierarchy of needs. Correct the correctable. So we know that many cases of dry skin and Paritis can be avoided by diligent skincare. An unrelenting itch can lead to a sense of helplessness in these patients and frustration, and then it turns into distress. So why not curb that problem before it even starts? The other thing, when you're talking to patients about the care plan, bring them into it. Talk about why we are choosing not to use palm olive over the white bar soap known as a bird dove. They want to be part of it, and you need to share that, because if you don't get them on board, they're not going to buy into this. So correct the correctable. So what this means to me is we need to fix the small things and not look at the big things we can't control. We live in Colorado. It's dry, horribly dry. For most patients, I can't correct that. They're going to live here. I have had a handful of patients who say, this is unmanageable. I do much better in San Diego. Peace out. I'm moving. And that's okay. I'm happy to help them if that's what they think to do. But for the most patients, they're not going to move out of Colorado. We are stuck with good old dry skin. But what can we do? We can put a humidifier in our house. That seems pretty simple and a lot cheaper than a move to San Diego. So going back, we're going to talk about bathing habits. So twice a day bathing is not good. You heard it here first. All of you smell wonderful. You don't need to, shower twice a day. So patients are highly offended. Well, I work out. I'm in the garden. That's great. Grab a towel, wipe off. You're going to be okay. So I get them on board to say, I just want you to go through some lifestyle changes to see if this makes a difference. Most people can go 2-4 weeks with some lifestyle changes. These are small ask of patients. So I tell them, back off on the showers. Maybe every 2-3 days, get in the shower. Get in and get out. No dallying around. I don't want anybody coming out looking like a lobster. Lobsters are bad. So when we shower, everybody gets in, the water's warm, and we have a tendency to stand there with our back to the hot water, and it feels really good mentally, but our skin is screaming. Do not stand there for 15 minutes to our back to the water, because everybody goes, I'm itchy right back here. Well, are you standing? Yes, yes, yes. So get in, get out, do your business. So most of us are not out in the garden or running a marathon every day. So there is no reason to scrub your head to toes with washcloths or loofahs or sponges or brushes. We have these, see, hands. So a little bit of soap or a bar of soap in your hands. And what I tell patients, under the breast, groin, backside, armpits. That's it. And the looks I get are, oh my gosh, everybody's going to see I smell. Nope, you don't smell. So those are the areas that produce odor, fluids, other things. If you are in the garden, you're rolling around the dirt, sure, get some of that dirt off your arm. But for the most part, water does a very good job of cleaning. So first of all, hands, boring basic soap, limit the showers. We're not big fans of people getting in the bath because the bath does dry out your skin. So limit the showers. Fragrance-free soaps. Lots of folks like to go to Natural Grocers or Vitamin Cottage or Whole Foods, and they go, I got the best smelling soap. Yeah, it does smell good, but your skin is not happy. So this goes back to the products they bring in. They're laid out for me, and what I do is I categorize them. I move everything around while the patient's in there. I never say, throw that away, because people get pretty miffed when you say, yeah, throw away your $30 bottle of lotion. Like, it's horrible. Nobody wants to hear that. So what I tell them, I say, put on the back of the counter. We're not going to use it right now. And down the line, when you get better, we're going to bring it back in. Ah, that sounds like a good thing. She's going to let me have that. Probably not. It's probably not coming back. But I'm not going to tell them that. So I give them a list of products. There's probably about maybe like 5 to 6 different soaps and lotions. I send them to Walmart or Target or King Soopers, and I said, take your list with your pictures and see which one matches up that you would like best, whatever's on sale. I said, I don't care. As long as it's off the list, I'm happy. The other thing you have to realize is what you're providing, and think about the socioeconomic background. There is a very popular product that comes in a nice jar with a blue and white label that I love dearly, but it's $15 a jar. That's a lot of money if you're on a fixed income. If push comes to shove, petrolatum, jelly, good old Vaseline is the cheapest stuff out there and the best bang for your buck. So think about that in the back of your mind. What status is in this patient? What are they on a fixed income? What can they afford? I've also had patients use tubs of Crisco because that's what fit in the budget. That's okay, as long as we're talking about it and getting something on board. White bar Dove soap at the dollar store is about $1. You know, that seems pretty manageable. So we've taken away all the products. We've told them what they can do, how they're going to shower, gone through the whole process. Do they do housework? Most of us do. I have a dishwasher, but I still do dishes. It's great. I have rubber gloves. They cost $2. My hands are very happy. We all wash our hands 20 million times a day. How many people use hot water to wash their hands? It feels good, but our hands don't like it. So lukewarm or cool water when you wash your hands. And then I also have patients, if they use the same sink throughout the day or at work, I have them take their own soap with them, so we're reducing more contacts. Humidifier in the bedroom or in the house can be helpful, and loose-fitting clothing. Look at their fingernails. This is part of your observation. If they have these beautiful long gel nails, I tell them, next time, let's trim those down. Because if they're long, they're gonna start scratching. Some patients need to wear gloves at bedtime. An alternative to gloves is white cotton tube socks. We all have them. They don't look stylish, but again, we don't care as long as it's helping with the itching. Limiting stress, I can't take away the stress, but just that reminder for patients sometimes can be helpful knowing this plays a part. Good healthy eating, lots of water, and limiting their exposure out in the UV or having sun protection. So let's say the patient comes back in 3 weeks and they go, Cally, I did correct the correctable. I've made all the lifestyle changes and I have the boring white soap that I use now and I can't shower and I smell bad. I'll say, well, now let's talk about some other options. Over-the-counter topical calamine, it's been around for years. Some patients find that very helpful. There's some menthol-based lotions that patients can do. Anesthetics, lidocaine and benzocaine. They're great if you have a tiny little spot, but if you're covering an entire body, we are concerned about systemic absorption. So I try to move patients away from those as best I can. Capsaicin is over the counter. Some patients love it, other ones don't, because capsaicin burns like the dickens. If you can get over the threshold of the burn, it can be very helpful. Application of it can be 3, 4, 5 times a day. And what actually happens is it calms those nerves down and decreases those impulse. The menthol products have a similar way that they work on the nerves. So patients tried over the counter, they come back. And now you see the Paritis and you see the itching. So you decide, well, maybe they need a topical steroid. So this is important to, again, document where it's located. Is it the arm, the eyelids, the neck? Because different skin has different thickness, and steroids have different potency, so we need to make sure we're choosing appropriately for those areas. This is where I go very strict on my documentation of saying, you're going to use product X on your arm, you're going to use product Y here. Everything I give out to patients is written in addition to verbal. I want patients to go home and go, oh, yep, that's exactly what she wrote down. Where and when should I be using it? The other thing you need to review with patients is how much. If you give patients a pound jar of a steroid, they will use it because it feels good. And if you're itchy, I'd use it too. But they're blowing through it in a week or two, it's not appropriate. We need to find a different option for them. But we also need to review with them, it's not lotion. It's not a substitute for using a lotion every day. Nobody ever told me. I did. It's documented. We're going to talk about it again. So just keep reinforcing how to use. Size helps for patients. Is it a pea? Is it a grape? How long should I put it on? Can I use this on my eyelids? And keep reinforcing not to use anybody at home's products because people love to use their spouse's prescriptions. Systemic medications can come into play, especially if they're having a hard time sleeping at night. H1 blockers at bedtime. Caution with sedation, especially in our elderly or people that are driving or using machinery. I really try to reserve these for the evening and rely on the H2 blockers like cetrizine or cimetidine during the day for patients. Doxepin is also a medication. It's a tricyclic antidepressant. We use it in dermatology for patients for itching. You have to be very cautious, though, because it does have a lot of drug interactions. And we try to limit it to about 2 to 4 weeks of use and then reevaluating. Physical treatments for itching. Phototherapy. This is something that's not widely available, but once you start looking, you can find it. We can also get home units for patients. This is our choice of treatment for patients with renal paritis. Psychological support. These people need somebody to talk to. If they're not sleeping, they're miserable, they're having relationship issues, they're having income issues, get them in with some therapy, cognitive behavioral therapy, support groups, anything for the itching. So the final step in our nursing care plan is our evaluation. How well did we do? Well, you don't know till you don't get the patient back. And if they're not doing good, guess what? They're going to be calling you, and they're going to tell you how miserable they are. So I always set an expectation. I tell them how long I expect before things should get better with the lifestyle changes, the correctable, or the topicals. And then I give them a follow-up appointment. I also tell them to keep in touch via the portal, send me messages. These patients want to be heard, and they want that level of communication. And guess who they get to talk to? The nurses. The nurses are the frontline people. You see them in the hallway, you're answering the phone. You guys are the ones that are taking care of these patients. So you have tools now to help these patients before they get into a situation where they're in that desperate state. So the purpose of our nursing evaluation is so we can check and see how we're doing. And again, we also need to document, go back in, document the goals, update the outcomes, how's it going? This is our way as nurses that we define, we explain, and we measure those nursing interventions. This is continuous, it's not static, so we have to keep updating it. So in conclusion, I want you to be aware of this because people just don't talk about itching all the time. People talk about pain and how they're peeing and their bowel movements. People are itchy. 15 to 60% of people that are receiving targeted therapy, they're going to get itchy. So if you looked back when I started my nursing care plan, I had a picture of a life jacket and a safety ring. Give the patients the life jacket. So we use a life jacket because if the water gets rough and we fall in, we got something. It's going to help us. So empower those patients because you guys are meeting with them first. You guys are the front line for these patients. Have them put on the life jacket and say, here are your tools if this happens, because there's a good chance. If you miss the opportunity, you throw the ring out. Now you have tools. But empower the patient, get ahead of it. We don't sit back as nurses and let problems happen. We try to intervene because I don't want anybody to be itchy. So second step on this is, third, I did my life jacket already. Documentation, listen. Document how that patient feels, put it in quotes, put it in the chart. These patients are miserable. Offer them that sitting down, that eye-to-eye contact, that kind support through this process. Because if we get through this, better options that they're going to be on that treatment plan for the cancer, and we're not going to have to modify it. Correct the correctable. We talked about the lifestyle changes. You all are going to go home and not shower twice a day today. You all are not going to use Palmolive in the shower or probably go in the bathroom and use scalding hot water. And then reassess. Keep checking in with these patients. I have a tickler list of patients that I know are at risk, and what I have done in the computer is I've set up messages that auto-send to them kind of at intervals just to check in. How's it going? And they want to hear that. They want to hear that somebody cares about their progress and how's it going and their support if they get in a bind. So this is my last slide. This is my family. I don't sail at all. I'm the one on the shore. So we can't change the wind, but you have sails. You can choose which sails you put up to alter the care of these patients. Empower yourself, empower the patients before the itching gets to that point. Thank you. Okay, so soaps you recommend for showering. Off the record, I will say name brands, if that's okay. White Bar Dove soap is my favorite, boring and basic, nothing fancy. People like to use baby products, but often you look on the back of thing and baby products have fragrance in them. Same thing if you go with a lot of the natural stuff. It'll say, oh, it's lavender or it's this. We would never rub poison ivy on our bodies, would we? And poison ivy is a natural product. So just keep it simple. I'm happy with Dove. I like Cetaphil. I like CeraVe. Nothing fancy. I keep it simple. Probiotic for Aveeno. Oh, I haven't tried that yet. I'll have to get a sample of that. So Aveeno prebiotic restorative cream for cancer patients. I'll look into that. And I go and I stand at the store, and if you've ever stood at Target and looked at all the products that are available or Googled itching and what you should use at home, it's overwhelming. So giving them a little bit of a list and support of what to take, and I put pictures on my list because some people are visual learners, and it's nice to have that photo to go, oh yeah, that's exactly the one that she recommended. A coworker who's experiencing chronic Paritis and she received COVID. During your assessment, have you ever found any correlation between the vaccine and the side effect? I have not. That could be interesting. And you mentioned that we shower in the U.S. 1 to 2 times a day. What is the optimal number? I'd say every other day to every third day, especially in the winter months here in Colorado. I've had patients present to the emergency room for dry skin. It's gotten so bad during the winter months, and we basically go back to Vaseline and wet wraps and topical steroids to get them back at baseline. So, any other questions?
Where does your husband sell his boat at?
Cherry Creek Reservoir.
Okay.
And last night he had to adjust the wind in the sails and save somebody. So, yes. But remember, yeah, a life jacket, for all applications for safety. So I thought about bringing my life jacket, but then I'd embarrass myself.